A warm welcome to our Congress coverage from ESMO. ESMO stands for the European Society of Medical Oncology. I would say it's one of the largest congresses that took place in Berlin this year, with almost 40,000 attendees.
Sherko, Kümmel and I were there. I'm very pleased that we are now turning to the topic of triple-negative breast cancer.
We have selected a few studies that we will now present, or rather Professor Kümmel will present them and then we will discuss them. So at this point, a warm welcome to you, Sherko. Maybe you'd like to briefly introduce yourself as well. And before I forget to mention it, we are recording this for patients today and Mamma Mia.
So, dear Alexandra, thank you very much for the invitation. Many thanks in advance as well to the team for what we have researched and worked on together, which we will now show you in this setting, what you can take away and what can actually be applied to routine practice in triple-negative breast cancer. So what does that mean for my day-to-day work in this situation? After that, we looked at what was available at the largest, I would say one of the largest cancer congresses in the world. And that means, again, no data is being withheld anymore just to travel to America and hear it there. But in Berlin, everything that was ready and possible to present was shown. My name is Sherko Kümmel, and I head the Interdisciplinary Breast Cancer Center at the Essen-Mitte clinics as part of a large women's cancer center. So, triple-negative breast cancer. These are always the women and patients who, after the diagnosis, everyone feels like an earthquake has hit their mind. And even more so in this case, because it's clear that we need chemotherapy in this situation. And in the vast majority of cases, this chemotherapy is given before administering it before the operation. That remains the standard throughout this whole. And here again is the disclaimer. These are my conflicts of interest. So now let's take a look at this. And many of you already know this or have heard about it in the whole context. Well, I had chemotherapy before the operation along with immunotherapy. Then I had the operation, and then for another half a year, I continued with immunotherapy as well. That's the standard for the whole thing. This is the standard if the tumor is 2 centimeters or if lymph nodes are positive. So that's called stage 2 or higher. And now, of course, many people are wondering, do I really have to undergo immunotherapy for this entire period in the whole process? Or can I perhaps have less of it in the overall situation? And in India, they have a study was conducted at a center in India, and they said, well, let's try giving less of it. Let's take a look at what comes out of it. Stage 2, 3, so that corresponds to the standard that I just mentioned from this Keynote 522 study, neoadjuvant, meaning not yet operated on, so to speak, in this situation. So 157 patients, and some might already be thinking, some very experienced listeners might think, well, is this really going to be practice changing with just 150 patients? Well, I won't give away the data just yet. It shows us something different for daily practice. It won't be practice changing with that number of patients. So in other words, what was done? Half of the patients received a short intensive chemotherapy cycle, 4 times this A or EC every 2 weeks, and 4 times paclitaxel, not 12 times, but 4 times every 2 weeks at a higher dose, so to speak, with this pembrolizumab, yes or no, so to speak, they received it. The first question was whether this so-called pathological complete remission is better. That means all tumor cells are gone at the time of surgery thanks to the chemoimmunotherapy, destroyed or only by the chemotherapy. What's the difference there? And can you achieve comparable results with less? Immunotherapy? Now let's take a look at this situation, and you can see that with immunotherapy, even when it was given less frequently, in the whole regimen, so only a few times and at a lower dose, so to speak, you still get a higher pathological complete remission rate. So in the whole picture. And now, of course, you're asking yourself, is this practice changing? So does that mean I just use even less immunotherapy and that's enough? The answer is clearly no. Why isn't it? Because firstly, we have only studied a small number of patients with this approach. Why not? Because, so to speak, we're missing certain situations like the use of carboplatin in the combination, which is often the standard today, because the duration of therapy is, so to speak, a bit longer, or the 12 cycles are a bit more. It's actually not comparable to the standard. And it also hasn't been compared to the standard. You would have to compare, if I only give it a few times now, at a low dosage, I would actually have to compare that to the standard when I give it for a year in order to say that it's equivalent, and that hasn't been done. Still, that doesn't mean this study is pointless. Because for me, this is a very important study. Why? There are a few patients, let's say roughly 2 to sometimes 8 or 9%, who, for example, can't tolerate pembrolizumab at all, meaning they experience side effects. And of course, they then say, okay, I only had it a few times, 2 or 3 times in total, so to speak. Was it all for nothing? Did I get no benefit from it at all? We can say that even if someone only received it a few times, with this endpoint here, pathological complete remission, is there already effectiveness? So we can tell patients who can't continue taking it due to side effects that they don't need to be as afraid. For me, that's the most important takeaway from this study. Of course, we see fewer side effects than if we administer it for a longer period and a more intensive chemotherapy. That's pretty clear. So it's not surprising. And that's essentially a key takeaway for me. That means where we have the Keynote 522 study, so classic chemotherapy, paclitaxel, carboplatin, followed by anthracycline, cyclophosphamide, the entire time with pembrolizumab, 200 milligrams every 3 weeks. And then again after surgery as well, so that remains the standard. But with this study, we can also help ease the worries of some patients who couldn't receive it, for example, due to side effects. And secondly, there are certainly regions in the world where people have to bear the full cost of these therapies themselves. And if within the family's available budget, the resources are simply limited, then you can tell them that even a few treatments already make a difference. I think that's an important message as well. Because we always forget that what we're discussing here with immunotherapies and so on, in the end, is only freely available to 20 to 30% of the population in insurance systems, the wealthy population.
I wanted to say we can really consider ourselves lucky to live where we do, and that such therapies are also covered here, that we shouldn't take that for granted.
We do like to complain about where we live, but in the end, if we take a closer look,
we should also remember to be truly grateful and appreciative for all the things that we have in our lives.
There are actually quite a lot of things that we can be satisfied with. That's why I've listed here again that there are also regions that unfortunately simply have no chance at all. In the whole picture, it does have significance, but for us, it doesn't change our practice. For me, the translation is, as I just said, for patients, so to speak, who cannot tolerate it or who have to discontinue it, that you can tell them that even in those cases, the first cycles probably already have some effectiveness.
Yes, I think that's a good way to deal with it, especially when you say, oh my God, oh my God, oh my God, I can't afford it or I can't tolerate it or whatever the reason may be, why people take it less often. There is still a lot of hope. That's why I also thought it was really important that we include the studies, even if the population isn't that large. Then they only took place at one clinic in New Delhi. But I think regarding the results, I think it's more about the small sample size and not that it was only at one location. Or how do you see it? Do you see a problem with that?
Yes, of course, they have completely different case numbers that they treat, but it is still an important point. Again, we see that with immunotherapy, we have 10% more patients who achieve a pathological complete remission. So that's already clear.
Yes, that means no detectable cancer cells anymore. That's wonderful.
And we know, of course, that this is the patient group with the best prognosis. So the more I increase that, the greater the effect on survival as well.
Yes, no guarantee, but a better chance. Okay, then let's take a look at the next study.
So, and then we come, so to speak, to a study called GeparNuevo. And anyone who has ever heard of Gepar probably thinks, isn't that something that comes from Germany? It all started with the Gepar studies like Gepar Duo, Trio, and so on. I've followed many of them, so to speak, throughout all of this. That's due to my age in this situation. And now we're at GeparNuevo. It's not numbered in this case, but it's a study that basically, once again, gives us the first indications where we stand if we want, need, or should de-escalate in all of this. So again, triple negative and patients, and this time patients whose tumors were smaller than 2 centimeters. Again, a small number, and some listeners said, well, then that's not practice changing. Again, it wasn't. First of all, it's an immunotherapy that we don't currently use, the durvalumab that was used there. And of course, it's not comparable to the Keynote 522 study, which I mentioned earlier. as the standard, so it hasn't been compared to that. But what does the study still show us? First of all, so to speak, we have a survival analysis here, where we once again, we're not just looking at pathological complete remission, but we're also taking another look at survival. In the end, that's really the decisive benchmark in all of this. Once again, we see that, so to speak, in the various situations, we see an improvement, yes, overall. And we've stratified this again, though that's not standard, when there are many immunocompetent cells. So to speak, this was shown by Professor Lübe from the GBG, the German breast group, so to speak. When there were many immunocompetent cells present, survival was also significantly higher. Still, it's not standard practice to measure these TILs in every patient. The next thing that we see again, so to speak, is that in the patients who received durvalumab, overall immunotherapy significantly improved survival. So immunotherapy provides additional survival benefit. And here, immunotherapy was only given in the neoadjuvant setting, meaning before surgery, not adjuvant. That's a very important message in the overall context. And here, let's look at this again in this situation. That means regardless of whether there was a pathological complete remission, and now it must be said, of course, with 170 patients, these are small case numbers, but such a curve, triple negative, 100%. So those who received durvalumab and had a PCR were only 40 patients, but all of them survived. So durvalumab was given and a PCR was achieved in the whole group, and it was given neoadjuvantly, meaning before surgery. Again, for me, what kind of translation is that? Immunotherapy, which is standard for us, it's pembrolizumab. When we use it, first of all, we have to use it neoadjuvantly. That's a very clear message, otherwise it doesn't help. That's extremely important. That means if I operate on the tumor first, I've already lost. That's a very, very important message for everyone out there, because of course, anyone who is confronted with such a diagnosis, they say, well, can't I just have surgery tomorrow? That would already solve a lot. No, that would be a mistake. That's the first message we take from this. Second, immunotherapy should become part of the treatment, because even if we give it less often, we see the same results as in the first study. That means even in patients who now have to discontinue pembrolizumab in the standard situation, they are, so to speak, benefiting from immunotherapy, even if they couldn't complete the entire course. If someone tolerates it well, I see no reason to deviate from the standard, because that is our standard that we should adhere to, where we currently have the best survival data. That is, for me, an important takeaway from these studies in this situation. So not practice changing, but again, the two main conclusions: treat neoadjuvantly. Second point, immunotherapy, neoadjuvant, and probably for patients who have to discontinue it due to side effects, we can convey the message that even just the first cycles of this immunotherapy already have effectiveness. That's what can be taken from this.
And what does it look like? Me again with my question about side effects. What does it look like? So pembrolizumab is an immunotherapy, durvalumab is an immunotherapy as well. Do they have the same side effects?
Yes, it's comparable overall. That means we see the rate of side effects, what we call in medicine, anything that can become inflamed, even if it's not tissue inflammation, as some might say, like pus or something like that. Yes, or anything like that, but rather it's an inflammation caused by the immune situation, triggered by changes in the immune system. So to speak, that can happen. Anything, you can get an inflammation of the intestines, you can get, I don't know, an inflammation of the heart, you can get a lung inflammation, all of that. But as I said, it's not always an infection that goes along with it, but rather due to the immunotherapy, it can, so to speak, the side effect can also affect hormone situations like the thyroid, which is the most common. For example, that's why you always have to check that regularly. That's part of immunotherapy. But in my opinion, the teams nowadays are already so well trained because of immunotherapies, since they are standard in many cases, that the teams who deal with them frequently can, so to speak, detect side effects very early on in blood tests and so on, and respond accordingly. And the treatment situation is then, of course, to stop the immunotherapy and give cortisone.
Okay, and can you explain again why it's so important that the immunotherapy is given before the surgery?
Yes, we have several studies, such as the BRAVE study or the IMPASSION study, so to speak, which first did chemotherapy or surgeries beforehand in triple negative cases, and then chemotherapy or chemoimmunotherapy, so chemo plus immunotherapy. And then the immunotherapy had no additional effect. That means immunotherapy needs the tumor or the tumor cells, which are attacked by chemo and are still in the body, that is in the breast, because chemotherapy destroys parts of the tumor, thereby creating what's called antigen presentation for the immune system, which is then activated. That's how you can imagine it. So that the immune system becomes capable of also attacking these tumor cells, so to speak. That's ultimately the explanation why we probably, or actually only have this situation in the neoadjuvant setting. That means if you first say, I'll operate, and then, if necessary, do it afterwards, first, you won't get it because the data simply doesn't support it. And second, it also doesn't work then.
Yes, that makes total sense. Know your enemy. If the immunotherapy doesn't know who it's dealing with, then the immune system can't learn either. Yes, wonderful. Then I would say, let's move straight on to the next study.
So, and now comes a study, so to speak, that has shown us, actually, it's not just for triple negative, but we included it because, of course, there are often patients, and you and many people know this. When you do dose-dense or intensified chemotherapy, you need support so that the bone marrow can quickly regenerate the white blood cells. That is, immune-competent cells, not for immunotherapy, but simply so that you can continue the chemo, can continue. So these ANC values that are measured, neutropenia, if they are too low, these white blood cells, if they are too low, the fever that is triggered, and so on. And then it was looked at, most people know this, when you give this injection on the first or second day, which is standard after chemotherapy, to, let's say, to stimulate this production in the bone marrow again. So the liposomal, let's say, GCSF, as it's called, in other words, pegfilgrastim, often causes bone pain. And now a study, actually quite simple, just looked at whether I give it on the first day after chemo, the second or the third, and how does that affect the pain? What does it show? And with a study like this, you might wonder, what's the point? But it actually means a lot because we do this, let's say, hundreds or even thousands of times a year here at the center, for example. So it has a big impact if we change our daily routine just because of this study. For instance, if we don't give it on the second day, but on the third, it's an important question. So let's take a look. Let's take a look at it. What did the data show us? What did our Asian colleagues prepare for us there? So chemotherapy treatment, so to speak, then bone pain as the main question. And pegfilgrastim was planned. So let's look at this. 24 hours, 48 or 72 hours after chemo. The standard is usually 24 or 48 hours. The main goal was, so to speak, bone pain, to measure it all. So now you see the results. After 24 hours, less pain. After 48 hours, the highest pain level. And after 72 hours, the least. So the conclusion for today is actually that the peak should occur on the third day, 72 hours after the chemo. Now, of course, some of you who have been following along will say to the team, yes, but what does that mean? Was I able to have less chemo because of it? Was it given because, for example, it wasn't as effective if I only gave it on the third day? By then, the chemo would already be long gone, would have left the body and already done its damage to the white blood cells. So the damage is already done. And if I only give it on the third day, maybe it's too late. And I end up with more patients with fever or with this drop of the white blood cells. Interesting question. So, of course, everyone was watching. In that particular situation, and here at the very bottom of the chart, we can clearly see cases of neutropenia or fever being presented. There is no significant difference observed between the groups in this regard.
Amazing.
So, a simple study with a significant and substantial impact. It just changes the way we think about a therapy routine that has been practiced for decades.
Yes, above all, I find it so impressive when you ask, does it make a difference?
That's why.
Nope. It actually doesn't matter when you give the injection, but does it make a difference for the quality of life of the patient? Yes,
exactly.
A huge one. I mean, that's really a wonderful message. And it's also good that things like this are being studied, that people say, okay, it's not like someone says, I'm going to profit from investigating this, or I can do something differently here, or save on a therapy or something. Everything is done in the same way, just at a different time, and you get such a huge improvement.
Exactly. We also started in our chemo outpatient clinic to schedule patients a day later. So in that sense, a study, usually day 2, sometimes day 1 in the whole process. So mostly
So you usually did it on day 2?
It balances out, depending also on how far patients have to travel to receive care. Some patients always travel farther distances, sometimes much farther, to get to the major centers where the specialized teams are in this situation. But as you can imagine, the travel requirements can vary from person to person. And this is something that needs to be considered carefully.
Yeah, I was just about to say, because if you schedule them for day 2 instead of day 1, then you're actually making it worse, if I understood that correctly.
Yes, but there is also a solution here. Yes, the patients can do it themselves.
Okay, so now it is even better. Yes.
It's a subcutaneous injection. That means in the end, it's no different than insulin. And if you train them well, guide them, take them by the hand and simply say, here, do it at home, not on the second, but on the first or second or even the third day. It works.
But just practically speaking, if I don't want to do it myself and I say, I actually don't want to give myself an injection, then can I also, if I took it home with me and said, I don't know, my husband or partner can do it, or could I also go to my family doctor with it? Would they give it to me as well?
Yeah, sure, I think so. Or the nurse at the front of the ambulance would probably do it while cleaning. That is why I wanted to say that again. Why do I have to go back and so on, all the hassle? In my opinion, you can do it yourself.
Yes, so there are options so that you don't have to make such a big trip just for an injection. That's actually good news.
I mean, everyone who was eager for Ozempic did it themselves too.
Great, I had to inject myself once too. You can actually practice that kind of thing.
So other studies, but you have to say it's doable. A lot of people know from the hospital, they've also received heparin injections and so on. So I think there are a lot of things where we can say, you don't need to be in the hospital for that or come back again. You can manage that well on your own.
Yes, perhaps at some point in the future, there will be another study that we can discuss together.
So a simple study, I think, pragmatic, just try it for 1, 2, or 3 days.
Yes, yeah.
Gives us a result and we can make changes without taking any risks. Perfect.
Great, that sounds great. Absolutely good. Good.
And that applies, as I said at the beginning, not just to triple negative patients, but always whenever we use these stimulators for the regeneration of white blood cells, such as GCSF. So during chemo, when I use it, I also use dose-dense intervals, sometimes with hormone receptor positive patients. And so I would also, now that has nothing to do with it. The bone pain from the injection has nothing to do with the biology of the tumor.
Yes, that's important. That should really be mentioned again for every indication that this is a very, very important result, which exactly. Yes, great. Yes, thank you very much. And that was our last study on the topic of triple negative breast cancer from ESMO that we brought with us. At this point, I would like to sincerely thank you again for your time, for explaining everything so well once again. And yes, it's always a pleasure to discuss this with you. And yes, also on behalf of Patients Today and Mamma Mia, thank you very much. And I'm already looking forward
to next time again.